Morning. Can everyone hear me? Okay. I want to thank Jody and Melanie as well for inviting me, the leadership of Individual Hearts, for inviting me to be on this panel with such wonderful clinicians and for assembling an outstanding program for CHD Symposium 2016. I'm really happy to be here to share our team science with the people I really hope that are going to benefit the most from it. And today I'm going to talk about some of the work we're doing in imaging, particularly MRI and a new technology called Flow. So the objectives of my talk this morning are going to talk to define some of the limitations that we face in caring for patients with congenital heart disease in terms of surveying them, risk stratifying them, and diagnosing them. And then to talk about how we think this new technique could help that process, this new technique called Flow. And then, time allowing, I'm going to take a deeper dive into what we think the promise of the Flow technology is in addressing and predicting clinical outcomes in congenital heart disease. So I wanted to start this morning just by taking a quick audience poll. We're talking about MRI, and I was just curious, how many people, patients, parents, have experienced cardiac MRI? So a good portion of this room. I'm really thrilled to see that because it represents a small number of tests, but it gives us a lot of information. And if you've had that MRI experience, how was it? Unpleasant, right? Yeah, it's loud. It's like being in a long tunnel. It's claustrophobic. It's long, right? How many people were in the scanner for 30 minutes? Keep your hands up. How many were in the scanner for 60 minutes? 90 minutes? Yes, 2 hours.
Oh my God.
Yes, I'm sorry, I apologize on behalf of my field. But we're trying to get much better at that, and Flow we think holds a lot of promise. Another question, how many were asked to hold your breath? How many could hold your breath as long as we asked you to? So there are a lot of limitations to MRI as it is today, and even with those limitations, patients that are 10 and older, most of them can cooperate, okay, with some part of the exam, maybe not complete the whole thing. And if they can't, for a baby, we have to feed and swaddle them and hope we get a diagnostic exam. Sometimes we do, sometimes we don't. And more often than not, for kids, we have to administer sedation. For children, it's usually general anesthesia, and we all know that there are risks associated with that, recovery associated with that, and significant cost associated with that. Sometimes when we weigh the risks of general anesthesia or the unpleasant nature of the MRI, we decide we're not going to do it at all. And so we either choose an inferior, less comprehensive test for the particular clinical question, or we have to choose a more invasive exam like a cardiac catheterization. And I'll talk a little bit more about that. And one thing I do want to point out is that cardiac MRI, while you need a lot of experience to interpret those exams, the people that are acquiring them, the technologists, need a really rich understanding of congenital heart disease as well. And they are a scarce commodity. They are liquid gold. When you really just, those people, you can't find them, you can't retain them, and it's another struggle we face. So why do we do MRI? Well, it does give us important information, and I don't have to tell you what the scope of that problem is. There are a lot of people with congenital heart disease. They're living longer. There are more than 1 million adults alive with congenital heart disease today. Some epidemiologists estimate that 1 in 150 young adults will have congenital heart disease this decade. So it's a problem with huge scope, large expense, just to care for the surgical inpatient care of patients with congenital heart disease is more than $2 billion a year in the United States alone. Moreover, because our patients are doing better and living longer, they need serial exams. We need to tell them, what are you at risk for? When do we need to see you next? And the decisions that we make sometimes are made on incomplete information for some of the reasons I talked about today. So how can we get more robust, hemodynamic, comprehensive information? And today I'm going to offer MRI as one possibility for that. And in the MRI world, we often find ourselves pitted between two really different worlds. the world of echocardiography. The picture on the left is some of our sonographers at Lurie Children's in the echo lab. I don't need to ask you to raise your hand if you had an echo. You all have, right? And that's because it's an extension of the stethoscope today. It's portable, it's relatively inexpensive, it's non-invasive. It gives us a good amount of information. But there are limitations. As we get older, it's harder to get acoustic windows to see the structures we need, especially outside of the heart. And so there are some real limitations. When we talk about function and size of the heart, we make a lot of geometric assumptions. We can't image necessarily the whole heart in 3 dimensions, so we have to cut it in slices and assume a shape for that. Well, that doesn't work for single ventricle heart disease. On the other hand, there's the cardiac cath lab, and Dr. Zahn is going to tell us about some of the amazing things that we can do in the cath lab to intervene and maybe minimize the invasiveness of surgery, improve recovery time. But if you go to the cardiac cath lab to make a diagnosis, it's a really expensive and risky way to accomplish that. And so we find that MRI usually inserts itself between those two worlds. And why? Because it gives us exquisite anatomic detail. We can diagnose a patient with single ventricle heart disease and a narrowed pulmonary artery and plan a surgery or a stent-based intervention that Dr. Zahn might perform so that they walk in with the information they need to treat that particular problem. Or we might avoid that intervention altogether by getting the right information. And anybody who has or has a child with tetralogy of flow is well aware how MRI has changed the paradigm for decision making in tetralogy of flow. We put these patients in the MRI scanner because it provides us the best information about the size of the right ventricle, about the leakiness of the pulmonary valve, to make a decision about following the patient, intervening, putting in a transcatheter pulmonary valve, putting in or taking the patient to the operating room. More importantly, it predicts adverse outcome. As we see the right ventricle enlarge and become dysfunctional, we know these patients are at higher risk for arrhythmias and life-threatening complications. So even though we run into these problems with MRI, we still perform the test. And it is highly modular, so we can tailor it for the specific patient. But in almost all exams, we're going to obtain some kind of scout image to help us plan the rest of the exam. We're going to get some ventricular size and function imaging that could take 20 or 30 minutes. We're going to get contrast angiography to give us the detailed blood vessel views that we talked about. And then we're going to get this hemodynamic information that I keep referring about, the flow information that only MRI gives us that lets us say, what is the cardiac output? How leaky is a valve? And in a patient with tetralogy of flow, at a minimum, we're going to do 4 of those acquisitions. We're going to look at the aorta, we're going to look at the main pulmonary artery, we're going to look at the branch pulmonary arteries to the lungs. If you're a Fontan, we might do that 12 times, equals the 2-hour exam that some of you have experienced. So we want to do better, and that really is where I think 4D flow enters and has high potential to replace the current kind of framework for imaging patients with congenital heart disease. This is a patient with Fontan physiology. There's some unique characteristics to this patient. You can right away see that there are 2 SVC that need to be hooked up to the pulmonary arteries to accomplish passive pulmonary blood flow. You can color code the origin and destination of blood flow with 4D flow. We could alternatively show the velocity of the blood flow to identify narrowings. You get anatomic information, you get functional information, you get physiology. Many of you will note this fenestration. Some of you may have had a Fontan or know people who had a Fontan that's fenestrated. Serves as a pop-up valve, can be important in certain physiology. We can measure all of these structures after the patient has left the scanner. We can measure the blood flow in each of these vessels from one acquisition, but without the patient laying on the table. And now this can be achieved in about 6 to 10 minutes. So that's 4D flow. How did we go from 2D to 4D flow? Why is it called 4D flow? I mentioned the planar image that we will do of a aorta or a main pulmonary artery in a patient with tetralogy of flow. Literally, we'll take a cross-section of the vessel, and this is what we call phase contrast or velocity encoded imaging. And all that means is that we're going to measure blood flow through a plane Bright white flow towards us is the fastest blood flowing toward us. Deep black is the fastest blood flow away from us. If you know the velocity of blood flow within a region of interest, you can estimate the flow, and you can get at things like valve regurgitation. So we want to do this throughout the chest, but if we did that through the whole volume of a child's chest, it'd be something like 4,000 images, and we'd have the patient in the scanner for a week. So the way that 4D flow has been accomplished is through modern innovations, including more powerful radio frequency gradients, improved and faster reconstruction, relies on the improved processing power that we have in our computers, compression techniques that take advantage of, and this is the genius of some of the physicists, sparsity of data, so they know, I don't need to sample this area of the chest as much as this area. So that's an oversimplification, but this is what these data look like. It literally is a stack through X dimension, Y dimension, and Z dimension of the chest over time. So 3 dimensions plus time, that's the 4th dimension, and that's 4D flow. And we've developed tools to look at these stacks of images in 3 dimensions. You don't need to be a doctor to know that this patient with a history of coarctation or narrowing of the aorta that Dr. Elzane talked about has developed an aneurysm in the descending thoracic aorta, and that there's abnormal blood flow in that area. Just with one picture, you're kind of getting a sense of what the hemodynamics are. Importantly, our group, other groups, Stanford and Madison, and several European centers have shown that we can do the same measurements that 2D acquisitions accomplish today with 4D with high reliability, good agreement, and good correlation. And we're moving closer and closer toward translating that into clinical practice. Okay, so we already realized that this technology has the potential to replace a current long, slow, noisy technology, and yield some really pretty pictures that make conveying information to surgeons and proceduralists really easy. But we're not satisfied with that. This data set we acquire through the chest gives us much more information. We're seeing higher order blood flow patterns. We're getting a window into helical and vortical flow. And we think that there's more information that we can get out of these kind of acquisitions. So in the time I have left in my talk, I'm going to touch on some of the emerging, we'll call them biomarkers, markers of disease that we think we can measure with 4D flow that might relate to clinical outcome and guide therapy for our patients with congenital heart disease. I'm not going to spend a lot of time, but we face some challenges, and we have a lot of teams and scientists working on overcoming some of these. Even though it's gotten to 6 to 10 minutes, it has to get faster with richer information. I don't have to tell patients and parents of patients with congenital heart disease that CHD is incredibly heterogeneous. No patient is the same. Disease processes are very different. And a Fontan patient may have low velocity blood flow to their lungs with a narrowing in the aorta. And we have to measure that all in one acquisition. So we need a wide dynamic range of velocities, and that presents some problems as well. And then we need to relate this to the primary disease processes. And so before I tell you what we're doing, I want to tell you who's doing it, at least at Northwestern. The gentleman in the top right picture here is Dr. Michael Markle, and he's my chief collaborator. He's a world-renowned physicist. He has almost 20 years of experience with MR method development. He's really one of the grandfathers of this 4D flow technique. We were really lucky at Northwestern to recruit him in 2012 to head up our MR cardiovascular research imaging unit. And he has taught me so much. He has an incredible understanding of clinical medicine for a PhD physicist, and that has made him an incredibly productive collaborator with me and many other people, including the Lurie children's team. This is our imaging team. These are the people that are acquiring these exams and our patients with congenital heart disease and trying to establish how they might change the way that we care for them. And I want to emphasize that it is a team and the infrastructure that makes this imaging possible today. So we were so lucky at the same time that Dr. Markle was recruited to move our children's hospital from Lincoln Park. We missed the leafy neighborhood, but we're happy to be down in Streeterville on the Northwestern Biomedical campus, where we have a cluster of computer scientists, biomedical engineers, and physicists working with our adult and pediatric teams to apply this technology. And we have a clinical translational research center where we have several research MRI scanners to develop these methods. And behind all of that, we have to connect all of these images we're obtaining with important clinical markers, right? So we need patient information, and there's an entire endeavor trying to consolidate the large electronic health records of 2 institutions, pediatric and adult, into a single registry that incorporates clinical information, tissue, and genetic samples, a biorepository, so we can do research and quality improvement work there. So let's talk about a specific disease process. I'm definitely going to talk about one. We'll see how the time is for a second. But I want to tell you that we're applying 4D flow to pretty much any form of congenital heart disease that you can think of. But I think there are a couple evolving stories that speak to why we need to continue to invest in this technology as a community. So I'm first going to talk about bicuspid aortic valve. Thank you for introducing that. It is a congenital aortic anomaly, and it is the result of abnormal formation of the aortic valve, where a normal valve has 3 leaflets, a bicuspid valve has 2, sometimes unicuspid at 1, either because of fusion or abnormal development. And valve disease is important in this population. Over time, patients can develop narrowing of the valve, leakiness of the valve, but there are some downstream effects that are equally important. And moreover, they don't necessarily correlate with the severity of valve disease. So a patient with bicuspid aortic valve can have coarctation. In fact, patients with coarctation of the aorta, 50% of them have bicuspid valve. They can also develop enlargement of the aorta over time. And as the aorta enlarges, it can become thinner walled, the wall becomes abnormal, and you can actually have rupture of that. And that's the catastrophic event that we never want to happen. But that we spend a lot of time thinking about what's the timing of intervention? When should we go in and fix that aorta, or when should we watch it? And like I said, it doesn't necessarily parallel the aortic valve disease. So we need ingenious strategies to follow that aortopathy, that abnormal aorta, in addition to the valve. In 4D flow, again, you don't need to be a doctor to recognize the difference between these 2 patients. On the left, that's a healthy, controlled patient, a normal patient, who has very linear, laminar flow through the aorta. You can see there's not a lot of changes in the velocity of the blood flow. In this picture, blue is slow blood flow, red is the fastest blood flow. But in the patient on the right, who has bicuspid aortic valve and a history of coarctation, you can see several disturbances in the flow. You can see helical and vortical blood flow in the ascending aorta. And you can kind of see a clockwise rotation. In addition, in the descending aorta, where that coarctation repair was, you can see acceleration and further disturbance in the laminar nature of blood flow. It turns out that the morphology of the aortic valve influences the pattern of that blood flow. And we've started to see patterns, and others have started to see patterns in that. And we think that that's an important signal that maybe this blood flow has an effect on the underlying tissue of the aorta. And so a theory has emerged that this aortic valve abnormality shapes the geometry of the aorta, leads to dilatation, might influence changes in the wall themselves that we see when we look at the gross pathology of the aorta that they take out when it's diseased. We see there are histologic changes that you can see under the microscope. And more importantly, we see these differences among patients. So what's going on there, and how can we relate these flow patterns to that tissue level progression? Today, the way that we decide whether to do surgery is we measure the aorta, right? If it's a certain size, we go in and we fix it. But that is really late in the game. Something has happened underneath over a long period of time that we need better insight into, so we might manage that process. And we think that that wall shear stress might have an important role in that, and that's something we can measure by MRI. So think of wall shear stress as the drag force on the wall of the aorta. So blood's flowing through the aorta, and it exerts a force on the wall of the blood vessel. if you have an abnormal aortic valve and flow disruption, that drag force is going to be asymmetric, and force may be exerted on one portion of the aorta in a way that it's not on another. We think that that causes changes in the makeup of the tissue of the aorta. And that's been proven in animal models. When you have a situation where there's increased asymmetric wall shear stress on an animal's aorta, we see disruption of the normal architecture of the cells that are forming that tissue. And so our hypothesis at Lurie was, well, what if we could measure wall shear stress, and at Northwestern, what if we could measure wall shear stress in bicuspid valve patients and correlate that with tissue? So we've proven that we can measure it in regions of the aorta, and in this picture you see these yellow discs represent circumferential wall shear stress on the wall of the aorta in regions. And the blue, where you see it higher in some areas, is a patient with bicuspid valve. Compared to the yellow controls, we see areas where wall shear stress is higher. So we know we can measure this, we know we can measure it reproducibly. And we move beyond that, now we can map wall shear stress onto a three-dimensional picture, because this is a volumetric acquisition, and generate sort of a map of wall shear stress for an individual patient. On the left is a normal control, on the right is a patient with bicuspid aortic valve, and you can see these areas of red where there's abnormal wall shear stress. Importantly, in order to compare normal to abnormal, we've scanned a lot of healthy patients, and we've noticed that wall shear stress changes as we age. And so in any patient, we can compare them to an age-matched control patient and say, yes, in your aorta, wall shear stress is elevated compared to somebody with the same gender and age. That's it. And we can then generate a map comparing the wall shear stress of a patient with bicuspid valve to a patient with normal wall shear stress, and generate what we call a heat map. In this heat map on the right, red connotates 2 standard deviations, extremely elevated wall shear stress in that region of the aorta compared to a normal control. We've reproduced this and published this in a number of different disease processes. But I tell you all of this to get at what we're most excited about, which is comparing these maps that we can say, yes, wall shear stress is elevated in a patient with bicuspid valve aortopathy, and then looking at the tissue underlying it. And we think that the flow that we're seeing by 4D flow and measurements of wall shear stress can predict these changes in the blood vessel lining.